Indication: CABOMETYX, cabozantinib, is indicated for the treatment of adult and pediatric patients 12 years of age and older with locally advanced or metastatic differentiated thyroid cancer, DTC, that has progressed following prior VEGFR-targeted therapy and who are radioactive iodine refractory or ineligible. Select important safety information. The full prescribing information for CABOMETYX includes warnings and precautions for hemorrhage, perforations and fistulas, thromboembolic events, hypertension and hypertensive crisis, cardiac failure, diarrhea, palmar plantar erythodysesthesia, proteinuria, osteonecrosis of the jaw, impaired wound healing, reversible posterior leukoencephalopathy syndrome, thyroid dysfunction, hypocalcemia, and embryo-fetal toxicity. Please see important safety information at the end of this video.
I'm Dr. Robert Alter, a hematologist-oncologist working at the John Thorold Cancer Center at Hackensack University Medical Center. I've been treating patients in the New Jersey community for more than 25 years, and am primarily involved in caring for patients with genitourinary and head and neck cancers.
And I'm Dr. Raji Shameem, a community medical oncologist and hematologist practicing in Florida. I have a special interest in targeted drug therapy. Today on CABOMETYX in Conversation, we're discussing a hypothetical patient named Sarah with radioactive iodine refractory metastatic differentiated thyroid cancer, also known as DTC. Sarah also has a BRAF V600E mutation. We hope to give you a sense of how we practice and make decisions in our clinic.
Sarah is a 62-year-old female who presented 2 years ago with difficulty swallowing and mild shortness of breath with exertion. Her physical exam identified a 4.5 centimeter thyroid nodule with palpable adenopathy and a biopsy-confirmed papillary thyroid carcinoma. She underwent a total thyroidectomy and lymph node dissection, followed by radioactive iodine therapy. 1 year later, lab studies revealed elevated thyroglobulin levels, with scans that revealed several lung and bone lesions. She was classified as radioactive iodine resistant.
Dr. Alter, the reality is that many of my colleagues in the community don't see patients with radioactive iodine refractory, DTC, very frequently. How would you approach treating a patient like Sarah?
Upon Sarah's diagnosis with radioactive iodine refractory metastatic differentiated thyroid cancer, my first consideration would be to submit her pathology slides for next-generation sequencing to identify any actionable mutations.
I'm curious, when do you typically recommend doing this sort of testing?
It depends on the situation, but if a patient was referred to me with RAR refractory DTC and hasn't had molecular testing done already, I'd request testing.
And what were the results of the testing?
Sarah was positive for the BRAF V600E mutation.
I also believe that next-generation sequencing is important because it may help to inform my approach to treatment. I know that BRAF V600E mutation is present in approximately 30 to 60% of all thyroid cancer patients, and BRAF mutations are significantly more common in patients with papillary thyroid cancer, which is the most common type of DTC we see in the clinic. BRAF V600E mutations are also associated with aggressive tumor biology, poor prognosis, and increased likelihood of being radioactive iodine refractory, which elevates the importance of being thoughtful with my treatment approach. Dr. Alter, for patients similar to Sarah, which treatment option would you recommend?
Considering the patient's pulmonary symptoms, lenvatinib was started at 24 milligrams orally once daily and maintained for 16 months until progression. From there, I would choose CABOMETYX as the next line of therapy because it is supported by evidence in treating RAR refractory DTC patients who progressed on initial VEGF receptor therapy like lenvatinib. I would also counsel Sarah that I'm selecting this treatment because the data has demonstrated efficacy and safety in that setting, and I'm also familiar with managing its safety and tolerability. How would you approach Sarah's treatment?
I would also feel comfortable with choosing CABOMETYX as Sarah's next line of therapy. CABOMETYX provides supportive data for treating patients with BRAF V600E mutations as shown in the exploratory subgroup analysis from the COSMIC-311 trial. Now, Dr. Alter, can you share a bit more about your experience with CABOMETYX and your perspective on the COSMIC-311 data?
Sure. COSMIC-311 was a multi-center, double-blind, and placebo-controlled phase 3 trial enrolling 187 patients who were randomly assigned in a 2-to-1 fashion to receive either CABOMETYX 60 milligrams plus best supportive care or placebo plus best supportive care.
And I believe that the patients that were included in the trial had radioactive iodine refractory (DTC) and showed progression after receiving prior therapy with a VEGF receptor inhibitor, specifically either sorafenib or lenvatinib, and some patients actually received both therapies.
Correct. And the trial began by evaluating two primary efficacy outcome measures. Initially, it assessed the overall response rate in the first 100 enrolled patients. Subsequently, the trial examined progression-free survival, or PFS, across all randomly assigned patients as the second primary endpoint.
And as I understand, there was also an updated analysis that evaluated a total of 258 randomized patients.
Yes, and relevant to Sarah's case, patients with prior genetic markers, such as BRAF mutations, were allowed to enroll, provided they had not received prior treatment with a BRAF inhibitor.
You mentioned earlier that one of the most important points of consideration when deciding on a treatment option for Sarah was the treatment's efficacy and safety profile.
Absolutely. And looking at the results of the COSMIC-311 trial, it's great to see that CABOMETYX delivered a significant benefit in primary PFS analysis. While the median PFS was not reached, the hazard ratio of 0.22 reflects a 78% reduction in the risk of progression or death.
Yes, then at the updated analysis, the median progression-free survival was 11 months in the CABOMETYX arm compared to 1.9 months for the placebo group. Those results in the placebo arm show that while DTC is generally thought of as an indolent cancer, patients like Sarah who are radioactive iodine refractory and who have progressed on prior VEGF receptor inhibitor therapy actually do have aggressive disease. Therefore, a median of 11 months is a notable difference for these patients.
Agreed. The 78% reduction in the risk of progression or death was also sustained, supporting the initial primary analysis findings, although no formal statistical testing was conducted at the time of the updated analysis.
Another factor that I consider, especially when treating a DTC patient moving on to second-line therapy, is tumor control. Did response rate play a role in your decision-making with Sarah?
Of course. When evaluating treatments, especially in the second line, I also place importance on reducing the size of the tumor and keeping a patient stable for as long as possible. While in COSMIC-311, the objective overall response rate did not reach a pre-specified endpoint for statistical significance, with a critical p-value of 0.01 in the objective response rate intent to treat. It's notable for me to know that 76% of patients showed a reduction in tumor size with CABOMETYX, and overall in the CABOMETYX arm, the disease control rate was 84% versus 42% in the placebo arm. The disease control rate is informative because it points out whether the majority of patients experience progression as their best response, which is reflected in improvement in PFS.
To me and my patients, safety and tolerability is another factor that matters a lot. What do you think about when starting a patient on CABOMETYX?
The clinical trial data is where I start. In COSMIC-311, the four highest adverse reactions in the CABOMETYX arm were diarrhea at 51%, PPE at 46%, fatigue at 42%, and hypertension at 30%. This, plus all other AR incidences, is information I like to keep in mind, especially when starting a patient like Sarah on therapy. It helps me actively manage a patient's therapy and use dose modifications as needed.
I share the same thoughts. Furthermore, in the COSMIC-311 trial, the efficacy of CABOMETYX was achieved in the context of dose modifications. However, I always want to ensure that my patients have a reliable method to contact me or the office. This is crucial for reporting any toxicities so that adjustments or interventions can be made before their next appointment.
For me, I use dose reductions to address toxicities. What comforts me is that the study results were in the context of dose modifications.
Exactly. And to add to that, for COSMIC-311, there was a 5% discontinuation rate for CABOMETYX due to adverse reactions compared to 0% in the placebo arm. Now, we've talked about the results from COSMIC-311 in the ITT population, but you mentioned that Sarah's case involved a BRAF V600E mutation.
Yes. Another reason for choosing CABOMETYX is the supportive exploratory post-hoc subgroup analysis focusing on patients with BRAF V600E mutations.
Let's expand on that topic. In the exploratory subgroup analysis of COSMIC-311, 106 out of the 258 enrolled patients had tissue samples available for BRAF sequencing. Within this group, 28% of the patients in the CABOMETYX group exhibited the BRAF V600E mutation. Dr. Alter, what do you take away from this subgroup analysis?
While these are results from a relatively small exploratory post-hoc analysis, and the findings should be considered hypothesis generating, it's helpful for me to see that CABOMETYX was again associated with prolonged progression-free survival compared with placebo, regardless of the presence or absence of the BRAF mutation. In the BRAF V600E subgroup, the median PFS was 9.2 months with CABOMETYX versus 1.9 months with placebo. In the BRAF wild-type subgroup, the median PFS was 11.1 months with CABOMETYX and 1.9 months with placebo.
Let's also talk about treatment-related adverse reactions with the BRAF subgroup analysis. For me, it's compelling to see that the safety profiles of the exploratory BRAF subgroups were similar with the overall study population, and no new safety signals were reported in the subgroup analysis. For the BRAF wild-type patients, the two highest adverse reactions were diarrhea and PPE, which occurred in 32 patients and 20 patients respectively. For the BRAF V600E mutated patients, the highest treatment-emergent adverse reactions were PPE in 10 patients, followed by diarrhea and ALT/AST elevation, and hypertension in 9 patients.
Yes, exactly. Based on the data and my experience with CABOMETYX, I'm comfortable managing those safety concerns in SARA. Before we wrap this up, I should say another reason I felt confident selecting CABOMETYX for SARA was the guideline support.
Yes, it has a Category 1 recommendation from the National Comprehensive Cancer Network for patients with locally recurrent, advanced, and/or metastatic radioactive iodine refractory papillary thyroid cancer that has progressed following VEGF receptor targeted therapy if progression after sorafenib and/or lenvatinib. So in summary, when you're evaluating a second-line treatment option for SARA, what key evidence points do you consider?
A few key things come to mind. The COSMIC-311 patient population, to start. I feel good about choosing CABOMETYX because the clinical trial included patients that closely resemble those we see in our clinic, including Sarah, providing a solid foundation for its applicability in her case. In regards to the efficacy and safety of CABOMETYX, both stood out as a significant factor. I feel confident in CABOMETYX because the data presented showed a compelling balance between effectiveness and manageable safety concerns. And although the patient sample was small, no new safety signals were observed in the BRAF subgroups when compared to the overall population. Lastly, in regards to the BRAF mutation, the evidence in patients specifically with BRAF V600 mutational status added another layer of informative data. The positive exploratory results in this subgroup made me feel more secure in my choice, given Sarah's mutational profile.
Dr. Alter, thank you so much for talking about this case with me.
You're welcome. It was a pleasure. Stay tuned for the next patient management discussions in the CABOMETYX in Conversation video series.
Important safety information, warnings and precautions. Hemorrhage. CABOMETYX can cause severe and fatal hemorrhages. The incidence of grade 3 to 5 hemorrhagic events was 5% in CABOMETYX patients in RCC, HCC, and DTC studies. Discontinue CABOMETYX for grade 3 to 4 hemorrhage and before surgery. Do not administer to patients who have a recent history of hemorrhage, including hemoptysis, hematemesis, or melena. Perforations and fistulas. Fistulas, including fatal cases, and gastrointestinal GI perforations, including fatal cases, each occurred in 1% of CABOMETYX patients. Monitor for signs and symptoms, and discontinue CABOMETYX in patients with grade 4 fistulas or GI perforation. Thromboembolic events. CABOMETYX can cause arterial or venous thromboembolic events. Venous thromboembolism occurred in 7%, including 4% pulmonary embolism, and arterial thromboembolism in 2% of CABOMETYX patients. Fatal thrombotic events have occurred. Discontinue CABOMETYX in patients who develop an acute myocardial infarction or serious arterial or venous thromboembolic events. Hypertension and hypertensive crisis. CABOMETYX can cause hypertension, including hypertensive crisis. Hypertension was reported in 37%, 16% grade 3, and less than 1% grade 4 of CABOMETYX patients. In CABINET, N equals 195, hypertension occurred in 65%, 26% grade 3 of CABOMETYX patients. Do not initiate CABOMETYX in patients with uncontrolled hypertension. Monitor blood pressure regularly during CABOMETYX treatment. Withhold CABOMETYX for hypertension that is not adequately controlled. When controlled, resume at a reduced dose. Permanently discontinue CABOMETYX for severe hypertension that cannot be controlled with antihypertensive therapy or for hypertensive crisis. Cardiac failure. CABOMETYX can cause severe and fatal cardiac failure. Cardiac failure occurred in 0.5% of patients treated with CABOMETYX as a single agent, including fatal cardiac failure in 0.1% of patients. Consider baseline and periodic evaluations of left ventricular ejection fraction. Monitor for signs and symptoms of cardiovascular events. Withhold and resume at a reduced dose upon recovery, or permanently discontinue depending on the severity. Diarrhea. CABOMETYX can cause diarrhea, and it occurred in 62%, 10% grade 3, of treated patients. Monitor and manage patients using antidiarrheals as indicated. Withhold CABOMETYX until improvement to less than or equal to grade 1. Resume at a reduced dose. Palmar-plantar erythrodysesthesia, PPE. CABOMETYX can cause PPE, and it occurred in 45% of treated patients, 13% grade 3. Withhold CABOMETYX until PPE resolves or decreases to grade 1, and resume at a reduced dose for intolerable grade 2 PPE or grade 3 PPE. Proteinuria. Proteinuria was observed in 8% of CABOMETYX patients. Monitor urine protein regularly during CABOMETYX treatment. For grade 2 or 3 proteinuria, withhold CABOMETYX until improvement to less than or equal to grade 1 proteinuria. Resume CABOMETYX at a reduced dose. Discontinue CABOMETYX in patients who develop nephrotic syndrome. Osteonecrosis of the jaw, ONJ. CABOMETYX can cause ONJ, and it occurred in less than 1% of treated patients. Perform an oral examination prior to CABOMETYX initiation and periodically during treatment. Advise patients regarding good oral hygiene practices. Withhold CABOMETYX for at least 3 weeks prior to scheduled dental surgery or invasive dental procedures. Withhold CABOMETYX for development of ONJ until complete resolution. Resume at a reduced dose. Impaired wound healing. CABOMETYX can cause impaired wound healing. Withhold CABOMETYX for at least 3 weeks prior to elective surgery. Do not administer for at least 2 weeks after major surgery and until adequate wound healing. The safety of resumption of CABOMETYX after resolution of wound healing complications has not been established. Reversible posterior leukoencephalopathy syndrome, RPLS. CABOMETYX can cause RPLS. Perform evaluation for RPLS and diagnose by characteristic finding on MRI any patient presenting with seizures, headache, visual disturbances, confusion, or altered mental function. Discontinue CABOMETYX in patients who develop RPLS. Thyroid dysfunction. CABOMETYX can cause thyroid dysfunction, primarily hypothyroidism, and it occurred in 19% of treated patients, 0.4% grade 3. Assess for signs of thyroid dysfunction prior to the initiation of CABOMETYX and monitor for signs and symptoms during treatment. Hypocalcemia. CABOMETYX can cause hypocalcemia, with the highest incidence in DTC patients. Based on the safety population, hypocalcemia occurred in 13% of CABOMETYX patients, 2% grade 3 and 1% grade 4. Monitor blood calcium levels and replace calcium as necessary during treatment. Withhold and resume CABOMETYX at a reduced dose upon recovery, or permanently discontinue CABOMETYX depending on severity. Embryo-fetal toxicity. CABOMETYX can cause fetal harm. Advise pregnant women of the potential risk to a fetus, and advise females of reproductive potential to use effective contraception during treatment with CABOMETYX and for 4 months after the last dose. Adverse reactions. The most common, greater than or equal to 20% adverse reactions are CABOMETYX as a single agent, diarrhea, fatigue, PPE, decreased appetite, hypertension, nausea, vomiting, weight decreased, and constipation. Drug interactions. Strong CYP3A4 inhibitors. If co-administration with strong CYP3A4 inhibitors cannot be avoided, reduce the CABOMETYX dosage. Avoid grapefruit or grapefruit juice. Strong or moderate CYP3A4 inducers. If co-administration with strong or moderate CYP3A4 inducers cannot be avoided, increase the CABOMETYX dosage. Avoid St. John's wort. Use in specific populations. Lactation. Advise women not to breastfeed during CABOMETYX treatment and for 4 months after the final dose. Hepatic impairment. In patients with moderate hepatic impairment, reduce the CABOMETYX dosage. Avoid CABOMETYX in patients with severe hepatic impairment. Pediatric use. Physial widening has been observed in children with open growth plates when treated with CABOMETYX. Physial and longitudinal growth monitoring is recommended in children 12 years and older with open growth plates. Consider interrupting or discontinuing CABOMETYX if abnormalities occur. The safety and effectiveness of CABOMETYX in pediatric patients less than 12 years of age have not been established. Please see accompanying full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.